Welcome back to the Deep Dive. This is where you give us the source material articles, notes, research, and we dive right in. We pull out the key insights, the interesting bits, basically giving you the essential knowledge without you having to wade through it all.
And today's dive is into something pretty fundamental for public health here in the UK. We've got a set of notes focusing on notifiable diseases, specifically what they are and how the reporting actually works.
Exactly. So our aim today is to sift through these notes you sent over. We want to get a clear picture of, well, first, what diseases are on this list, but maybe more importantly, understand the system behind it, the why and the how of the reporting process.
Yeah, it might sound a bit dry, just administrative stuff, but actually these notes highlight some really crucial points. Things like statutory duties, very specific timings, and it kind of reveals how public health surveillance is meant to operate.
Okay, let's get into it then. Let's unpack this. So, starting with the basics from these sources.
Mm.
What actually is a notifiable disease in the UK context?
Well, fundamentally, it's an infectious disease that carries enough risk to public health that it legally must be reported to the authorities. The notes say this report usually goes first to someone called the proper officer at the local council, or maybe to a local health protection team.
Health protection teams.
Yeah,
Right, those are the local public health units, aren't they?
that's right. Yeah, the sort of frontline teams. And then, at least in England, according to these notes, that proper officer or the HPT reports the information onwards weekly to the UK Health Security Agency, which used to be the Health Protection Agency. It's about escalating that information from the individual case up the chain.
Right, so it's a formal tracking system. It's not just about the one patient. It's about spotting trends, potential outbreaks, and who kicks this off. Who's actually responsible for making that first report? The notes seem quite emphatic about the legal side of this.
Oh, absolutely. That's a really key detail here. The sources state very clearly that registered medical practitioners, doctors, have a statutory duty to notify.
Hang on, statutory duty. That sounds serious. That's not just guidance, is it? That means it's required by law.
Precisely. That's exactly what it means. The notes stress this point. It's not optional. It's not best practice advice. It's a legal requirement. If you're a registered doctor and you suspect one of these diseases, you're legally obligated to report it.
Okay. So if it's a legal requirement, this statutory duty,
Yeah.
how do they actually do it? What are the mechanics? What do the notes say about the procedure?
The procedures are quite specific, seemingly designed for, well, speed and getting the core info across. The main way is by filling out a notification form. And here's a really interesting point the sources highlight. You're supposed to complete that form immediately when you suspect the disease. Critically, before you even have lab confirmation.
Wow, okay, so not waiting for the test results. If a doctor sees a patient and clinically it looks strongly like, say, measles or maybe meningococcal septicemia, they report it straight away.
That's exactly what the notes say. Act on suspicion, don't wait. The written form then needs to be sent securely within 3 days of that initial suspicion. But there's another layer for urgent cases.
Urgent cases, like particularly dangerous ones.
Yeah, things where rapid public health action is critical. For those, the requirement is even faster. The notes say a verbal notification, so usually a phone call, is needed within 24 hours. So the whole system seems geared towards speed, especially in those high-risk situations. Acting on suspicion is key.
That makes a lot of sense, doesn't it? For infectious diseases, waiting a few days for a lab result could mean an outbreak spreads further. Getting that early warning allows the public health teams to jump into action, contact tracing, preventative advice, whatever's needed.
Exactly. That seems to be the underlying logic, judging by the urgency built into these procedures.
Ah.
It's also worth mentioning the notes point out slight differences in how you notify depending on where you are in the UK. So, for example, in Scotland, it says they require electronic notification through something called the Scottish Care Information Gateway, SCI Gateway.
Okay, so SCI Gateway is their specific digital system for this.
Seems like it, yeah. Whereas in England, as we said, it tends to be the local council, proper officer, or the HPT. And in Northern Ireland and Wales, the notes mention the proper officer of the local authority. So the principle is the same, get the info to the local public health people fast, but the specific mechanism might vary a bit.
Interesting. Same goal, slightly different paths to get there. Okay, so whether it's a form, a phone call, electronic submission, what information actually needs to be in that notification, the notes list quite a bit.
Yes, it's pretty comprehensive. You need the basic patient identifiers, of course. Name, date of birth, sex, their address, NHS number.
And ethnicity is in there too, which the notes mention. That's important for tracking health inequalities, right?
Definitely. Also needed is their occupation, or maybe school or workplace if that's relevant. Their current residence if it's different from their main address, a contact number. And if it's a child, the parent's contact details too.
Okay, and then the clinical stuff.
Right. The specific disease or infection suspected, obviously.
Mhm.
The date the symptoms started, the date of diagnosis, if that's known. And this is quite significant. Any relevant overseas travel history.
Travel history. Crucial for tracking imported cases and global spread. Makes sense.
Yeah. And there's more if the patient is in hospital. You need the hospital address, when they were admitted, and crucially, there's a chance they actually caught the infection in the hospital.
Right, for spotting healthcare-associated infections. That's vital.
hmm And one final detail the sources add, apparently there used to be a fee paid to doctors for doing this, but that's no longer the case.
Oh, interesting. So the incentive now is purely the legal duty and, well, public health good.
Seems that way. It's about the requirement and the importance of the data itself.
That is a lot of detail for every suspected case. It really paints a picture of how much information the authorities want to gather for surveillance. It's designed to be thorough. Yeah. Which, leads us nicely to the actual list. What diseases are we talking about here? What's currently notifiable according to these sources? Well, the list is pretty long and covers some serious stuff. You've got diseases you hear about like COVID-19, measles, tuberculosis, but also things that are perhaps rarer now but still carry significant risk. Things like anthrax, cholera, botulism, diphtheria, meningococcal, septicemia, plague, rabies, yellow fever. Quite a range.
And the sources also point out the list isn't set in stone. It changes over time. They mentioned, for instance, that back in April 2010, several diseases were actually removed from the list. Things like dysentery, ophthalmia, neonatorum, leptospirosis, relapsing fever. So it suggests the list gets reviewed and updated based on, well, current public health priorities, maybe how common diseases are, or that there are other ways to track them effectively.
Interesting. So it adapts. And the notes also flag up one quite notable exception to the list. Yes, HIV. Even though it's obviously a major public health concern, the notes explicitly state HIV is an exception. It's not notifiable under this specific mandatory reporting system that requires doctors to report individual suspected cases in this way. There are separate surveillance systems for HIV.
Right. And while the notes do include a table showing some minor variations in the lists across the different UK nations, England, Northern Ireland, Scotland, Wales.
Reflecting slightly different priorities or maybe disease patterns locally.
Yeah, but the core list of major threats seems largely consistent across the board. That common list really forms the backbone of this whole surveillance effort.
So we pull that together. This list basically represents the diseases deemed serious enough from a public health standpoint in the UK to warrant this formal, legally mandated reporting by doctors. It's the official trigger list.
Okay, so we've got the definition of this really strong statutory duty, the quite detailed procedures, including that report on suspicion aspect, and the comprehensive info needed. It honestly sounds like a pretty robust system on paper, designed to catch things early. It certainly appears designed that way, yes. Very thorough.
There's always a but, isn't there? The sources include this section, comments on reporting, and it seems to throw a bit of a spanner in the works.
It does, somewhat. This section mentions evidence suggesting there's actually widespread underreporting and a lack of compliance with these very guidelines we've just discussed. And it notes this isn't just a UK problem either. The sources suggest it's an issue seen internationally as well.
Okay, hold on. This is where it gets genuinely puzzling for me. We just established it's a statutory duty, a legal requirement for doctors. So how can there be evidence of widespread underreporting? If it's the law, shouldn't compliance be much higher? Doesn't statutory imply consequences for not doing it?
It's a really good question, and it highlights a potential gap. The sources simply state that evidence suggests this lack of compliance exists, despite the legal footing. It definitely presents a challenge to how effective the system is in practice, compared to how it's designed on paper.
So we have this meticulously designed system, clear legal duties, specific processes. But the reality, according to these notes, might be quite different, with significant underreporting happening. That's a really fascinating and maybe slightly concerning disconnect.
It is a tension highlighted right there in the source material. And it's something public health authorities are almost certainly aware of, and, you'd imagine, trying to figure out how to improve.
So thinking about you, our listener, why does understanding all this matter? Well, it gives you a real window into how our public health infrastructure is supposed to function at a fundamental level. You can see the process for tracking diseases. You understand the crucial, legally mandated role doctors play beyond just treating patients. And importantly, it also shows the real-world complexities in gathering accurate data, even when laws are in place.
Yeah, it's a core piece of the puzzle in how society tries to monitor and control infectious disease spread.
Okay, so just to quickly recap. We've looked at what notifiable diseases are, the legal statutory duty on doctors, the specific reporting steps, including that immediate reporting based on suspicion, the detailed information required, the kinds of diseases on the list, plus those removed, and the exception of HIV.
And crucially, we've touched on that challenge mentioned in the sources. The evidence suggesting underreporting, despite the system's design.
Right, which leaves us with a final thought for you to chew on. If reporting these diseases is a legal duty, and it's clearly vital for protecting public health, allowing for tracking and rapid response, what are the potential knock-on effects for individuals who might be exposed, and for our collective ability to manage outbreaks if this underreporting noted in the sources is indeed happening on a wide scale? What could be causing that gap between the rules and the reality, and what does it mean for all of us?
Definitely something to think about. Thanks for diving deep with us today.
We really hope exploring these sources on UK notifiable diseases has been useful and maybe sparked some new questions for you.